Hello, my name is Harry Singh. I am a medical resident at St. Agnes Medical Center, Fresno, California, and I would like to present a very unique case to ACP. The coronavirus pandemic has brought many new challenges upon the medical community, along with many new pathologic findings. As it is most notorious for causing inflammatory changes and subsequent damage to the lung, it brings with it a unique opportunity to document the radiographic findings of both its disease presentation and its progress over time. The patient discussed in his case report had COVID-19 pneumonia one month prior to her presentation, who came again with typical symptoms of COVID-19, including shortness of breath and cough. Chest radiographic imaging showed an abnormality in the right upper lung field, which was further differentiated on CT scan to be a large cavitary lung lesion with thick irregular walls. Cavitary lung lesions are typically seen with infections like fungus, parasite, mycobacterium, and in autoimmune diseases or malignancies. We present a case in which all other causes of cavitary lesions had been ruled out, and the cavitary lesion was likely a sequelae of COVID-19 pneumonia. In this case presentation, a 30-year-old Hispanic female with a past medical history of asthma and poorly controlled diabetes was presented to the ED with a chief complaint of shortness of breath and productive cough, of white sputum flecked with blood. Associated symptoms included dyspnea at rest, subjective fevers, fatigue, nausea, and diarrhea. She denied any chills, night sweats, or hematemesis. In the ED, she was found to be positive for COVID-19, and according to the patients, she likely acquired the infection 1 month prior when her whole family tested positive and she was symptomatic at that time. She denied any travel in the year prior with no exposure to mountains, caves, birds, or chicken coop droppings. And since the birth of her child 3 months prior, patient has been taking very poor care of her health and noticed an unintentional weight loss of 24 pounds associated with very poor glucose control. In the ED, the patient was found to be tachycardic. Her physical exam was significant for absent lung sounds in the right upper lung fields, and coarse breath sounds was appreciated throughout the rest of her lung fields. No peripheral edema was appreciated. Her point of care glucose was in the 300s, and her HbA1c was 12.2%. At this time, I'd like to present her radiographic findings. In Figure 1, you can appreciate a CT scan with contrast of the axial view of the thorax. Large cavitary lesion in the posterior right lung field was appreciated with wall thickening, measuring 10.2 by 6.4 centimeters, width and height respectively. The cavitary space itself was 5.9 by 3.3 centimeters, width and height respectively. In Figure 2, CT scan of the sagittal view of the thorax appreciates a large cavitary lesion in the superior posterior right lung field with wall thickening. The cavitary lesion measured 5 by 9.5 centimeters, width and height respectively, and the space measured 2.7 by 4.9 centimeters, width and height respectively. Figure 3 appreciates a CT scan of the coronal view of the thorax with large cavitary lesion in the superior right lung fields, measuring 10.1 by 8.3 centimeters, base and height respectively, with the space itself measuring 6.2 by 5.8 centimeters, base and height respectively. Along with these imaging, we also tested the patient for cryptococcal antigen, coccidioides antibody, aspergillus antigen, HIV test, 1,3-beta-glucan D, quantiferon gold tests, which were all found to be negative. Pulmonology was consulted, and a bronchoscopy with bronchoalveolar lavage was done, which showed normal airways. BAL and microbrush was sent for cultures and cytology, sensitivity, gram stain, fungal, viruses, AFB, cocci, PCR, SARS-CoV-2, aspergillus EIA, and beta-D-glucan, which were all found to be negative. During the course of her admission of 6 days, the patient never required supplemental O2. Her shortness of breath and cough improved. She was discharged to follow up with the pulmonologist outpatient, and upon follow-up at 3 months, patient remained asymptomatic. However, she did not follow up with pulmonology. Our case highlights the importance of studying the continuously evolving late complications of COVID-19, as long-term studies are still being conducted. Cavitary lesions due to COVID-19 are rare, with only a few documented cases, and the mechanism involved is unclear at this time. There are a wide array of cavitary lesions that can be appreciated on CT findings, and typically a combination of both the imaging and clinical history aid in forming a diagnosis of the suspected source of the lesion, whether it's acute or chronic, benign or malignant, or whether it's infectious or cystic. Clinical presentation in patient's recent history is invaluable in helping diagnose an infectious source of pulmonary cavitations. For example, a pulmonary abscess presents as cavitary lung lesion and is typically accompanied by air fluid levels and symptoms of infections. These are most notoriously seen in pneumonia, but it can also present with septic emboli. Cavitary lung lesions can also manifest in patients that were previously sensitized to M. tuberculosis or patients that are presented with pulmonary aspergillosis. Typically, a more indolent course of progression in comparison to a rapid progression is seen in non-infectious sources. Several systemic processes can present with cavitary lung lesions, for example, granulomatosis with polyangiitis, rheumatoid disease, and sarcoidosis. A more indolent course still can manifest in malignancies. In fact, the most commonly encountered solitary cavitary nodule in the lung is a malignant tumor. Developing a cavitary lesion as a complication of COVID-19 is not common, and although only a few cases have been reported, and the exact mechanism of development of cavitary lung lesions in COVID-19 is unknown, there have been studies that show that autopsy reports suggest that it is linked to diffuse alveolar injury, intraalveolar hemorrhage, and parenchymal cell necrosis. It is imperative to keep a broad differential in mind when addressing pulmonary cavitary lesions and ruling out infectious sources as well as systemic and malignant sources. However, as the presence of COVID-19 pneumonia continues to be felt on a global scale, a complication of cavitary lesions should be kept in mind as physicians follow up with patients. Thank you for your time.